You are welcome to my channel once again. Today I'll be addressing hemophagocytic lympho histiocytosis, but I'll be limiting myself to the treatment only. If you haven't listened to the two previous presentations on HLH, please kindly do. Treatment. The lifespan is drastically reduced to a few months if there is no early treatment. Early diagnosis and treatment is the key. We have to treat at the slightest suspicion. Like those who would have listened to my first presentation on on HLH, particularly while making the diagnosis, the key to diagnosis is high level of suspicion. With multiple organ failure, death is imminent. In about 30 years ago, the protocol for HLH was developed, and that has reduced the mortality by half within 6 years. HLH 94 protocol will make use of dexamethasone with etoposide. If central nervous system disease is involved, then they will use intrathecal methotrexate with hydrocortisone. If central nervous system disease with gene mutation and relapse is occurring, then you use hematopoietic stem cell transplantation. In 2004, a new protocol surfaced. Here, cyclosporine became useful, and that will be used earlier in the treatment. Hydrocortisone with methotrexate will be helpful for intrathecal administration. You can start treatment if inflammation is ongoing with increased ferritin greater than 10,000 nanogram per ml, or you have increased D-dimer or increased liver enzymes, with or without genetic screening outcome. Treat any identified triggers, such as hematological condition. Treat the underlying malignancy if there's any malignancy related, particularly hematopoietic in origin. Send consult to hematologist. Also involve the oncologist. Hematopoietic stem cell transplantation will be very helpful. Don't waste time to embark on that. Monitoring. We can monitor this disease, that is HLH, using some biomarkers like liver function tests, complete blood count, D-dimer, ferritin, fibrinogen, and soluble hemoglobin aptoglobin scavenger receptor, SCD163. Check out for the triggers and treat appropriately. For example, if it is infection with fungi, have antifungal. If it's bacteria, antibiotics. If it is viral, antiviral agent. And if it is parasite, get antiparasitic medications. If it is malignancy, treat appropriately with the help of oncologist. If it is Epstein-Barr virus, get intravenous immunoglobulin or disease-modifying anti-rheumatic drug. If it is HIV, grab your highly active antiretroviral therapy. If you've done all and the situation is not improving or actually is even getting worse, then we have to commence HLA-specific therapy. What is HLA-specific therapy? We can choose from dexamethasone, hydrocortisone, prednisone, cyclosporine, and methotrexate. You can also choose from vincristine with cyclophosphamide, doxorubicin, oncovin, etoposide, blood transfusion if so required, fresh fluorescein plasma, hematopoietic stem cell transplantation with the help of the oncologist, emapalum. The prognosis, very high mortality, and that is sad to know. Mortality is pretty high here. HLA-94 protocol will afford HLH disease patients, and about 54 of them to live up to 6 years. 2 months is the lifespan. That is 2 months to death if the inherited form is what the child is having and is untreated. It's going to be the worst prognosis if central nervous system is involved. In children less than 6 months old, the chances of survival is pretty low. You could see that when I reach this page, I'm going very slowly because it's pretty sad. The prognosis is not good here. Hematopoietic stem cell transplantation will afford the affected people, in about 60% of them, to live up to 5 years. Complications. Liver failure. Remember, histiocytes will be found in the liver, now doing massive damage right there. That's why liver enzymes will be high and there will be bilirubin, very high. So giving us liver function, impairment, including clotting factors. Renal failure, that's a big problem. Respiratory failure will lead to death faster. And of course, central nervous system degeneration. Relapse is very possible. So the fact that you've made the correct diagnosis, instituted the correct management, is not to say that is the end of the road. We might not be out of the wood yet because there's the likelihood of relapse. You can, however, reduce relapse by reducing exposure to the trigger or triggers. So it's pretty important to know the trigger or triggers if it is not genetic in origin. With that, I've come to the end of this presentation. It is one thing to have suspicion that this is HLH. It's another thing to make the definitive diagnosis of HLH. Then it is great to embark on correct management. Then the child will grow and be grateful later in life. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.